Hello friends, continuing the session of Case of the Week by IRIA Gujarat State Chapter, I am going to share with you an interesting case that we recently did. I am Dr. Ankur Shah, Consultant Radiologist at Sadbhav Imaging Center, Ahmedabad. A 24-year-old patient presented with history of trauma and pain in the anterior aspect of knee joint. Radiograph of knee joint was performed with lateral and skyline view of patella, which did not show significant abnormality. As the patient had continued symptoms, MRI of knee joint was done after 3 weeks of onset of symptoms. MRI showed a focal area of abnormal bone marrow edema involving patella, which was more marked at the lateral aspect. The doubts were, is it a bone contusion or there is some underlying lesion? When we asked the history in detail, the trauma which occurred was not very significant, but it was a trivial trauma when the patient had hit his knee joint with a table, and such kind of injury rarely causes so much of bone marrow edema. So we had doubt that there is some lesion in patella and not just bone marrow edema. But the patient was reluctant to get a biopsy done and the patient was kept in a close follow-up. A repeat MRI of knee joint was done after 4 months of the onset of symptoms. The repeat MRI showed significant increase in the bone marrow edema and now it was involving almost entire patella. Just that, the edematous changes were also extending to adjacent soft tissue. CT scan showed small areas of erosions within the patella. Blood investigations were done which showed increase in the ESR with normal CRP. Still, biopsy was not done and a repeat MR of knee joint was done after 2 months of the previous MRI. Repeat MRI showed some regression in the bone marrow edema, but there was a well-defined lesion involving patella which was well appreciated now. On sagittal images, you can see there are 3 discrete lesions which are involving patella with some edematous changes adjacent to it. On diffusion weighted images, a few of the lesions were showing diffusion restriction. On CT scan, the osteolytic lesions were very well seen, which were well demarcated, and one of the lesion was even reaching up to the cortex. The differential possibilities were, is it a resolving bone contusion, is it a neoplastic lesion, or it is a low-grade infection. Resolving bone contusion looks very less likely looking at the sequential scans. For neoplastic lesion, again, the possibility is less because initially it was presented with only bone marrow edema and gradually there was a well demarcated lesion. Biopsy was done in a week after the MRI and biopsy showed presence of Mycobacterium tuberculosis, which was rifampicin resistant. Even AFB culture was performed and which showed presence of Mycobacterium tuberculosis. Patient was put on AKT and this is the post-procedure MRI which showed areas of biopsy tract with some edematous changes in adjacent soft tissue. The patellar lesion is very well appreciated. Follow-up MRI was done 10 months after starting of AKT and that showed significant improvement with marked regression in the bone marrow edema as well as the size of the lesion. The patient significantly improved clinically as well. And a further follow-up which was done after 6 months of last MRI showed further regression in the size of the lesion and the patient did not have any clinical symptoms by this time. So this was a case of proved Mycobacterium tuberculosis which was rifampicin resistant and responded well to the antituberculous treatment. Teaching points for this case are Get the proper clinical history. Do not get misguided by history of trauma, which might be trivial sometimes. Whenever in doubt, do a close follow-up. Once you exclude, do not touch lesions. Don't hesitate to get a biopsy done in all indeterminate osseous lesions. And always keep common conditions in mind before directly jumping to the very rare lesions. Thank you so much.